So, hi Yasmin, my name is Melissa. I'll be your student nurse today. So, I'm going to wash my hands. I'm going to sit down with my patient and talk about the assessment. So, today I'm going to be doing a cardiac assessment, and I just want to tell you a little bit about it, how you can help me out, and how things can go smoothly. What I'm going to do is I'm going to ask you a few questions, a little bit of an interview, and then I'm going to be feeling your chest and then listening to your chest and then doing more in-depth assessments with you. Is that okay with you?
Yeah.
Okay, so you will have to expose your chest. Okay, so the first question I'm going to ask you is a little bit about your history. Do you have any history of cardiac diseases like heart failure, had any heart attacks, coronary artery disease, cardiomyopathy, anything like that?
No.
What about your family history? Do you have anybody in your family that's have had any of those? Heart failure, heart attacks,
No.
blood clots, nothing? Okay. Then I'm going to identify some of the risk factors. Do you smoke at all? Vape? Okay. Do you have high cholesterol?
No.
Okay. And then do you have diabetes?
No.
Okay. So next I'm going to talk a little bit about what you do for a living. Do you get enough exercise at work? Do you sit for long periods of time, like a desk job, truck driver, or do you get adequate amount of exercise throughout the day? Adequate amount? Okay, that's good. So next I'm going to be asking you a little bit about some signs and symptoms. Or first, I'm going to ask you a little bit about medications. Do you take any blood thinners such as warfarin, aspirin, any blood pressure meds like metoprolol, ACE inhibitors like lisinopril, any over-the-counter meds like Tylenol and ibuprofen?
And sometimes, yeah.
Okay. Do you take any herbal supplements?
No.
Do you take any digoxin?
No.
Okay. All right, that's good. So next I'm going to ask you a little bit about some signs and symptoms. Do you ever get numbness and tingling in your feet or your hands?
No.
Do you ever get any swelling, abnormal swelling?
No.
Any chest pain?
No.
Difficulty breathing, headaches, any lightheadedness?
No.
Okay. Okay, so the next thing I'm going to do is I'm going to just inspect you a little bit, take a look at everything. First, I'm going to have you put your hair back. Okay, and then I'm taking a look at her jugular vein. So I'm making sure that it's not distended because that could indicate right-sided heart failure. So I'm going to have my patient look to the left. And I'm looking here, no signs of distension. And then I'm going to have her look to the right. And okay, no signs of distension. I'm taking a look at her lips and they look pink and nice and moist. Looks like there's adequate perfusion. So that's good. That means that there's no cyanosis, no pallor, and that the blood is oxygenating everything. Next, I am going to take a look at her nails. So what I'm going to have you do is I'm going to have you put your fingers together. Okay, and they're touching and they don't seem really round. If her nail beds were round, that could mean clubbing, and typically patients with COPD have this due to them not getting enough oxygen to their extremities or to any of the tissues. So that is good too. I'm also looking at her chest, making sure that it's not barrel shaped. Again, typically patients with COPD have a barrel chest. Do you have any pain, cramping in your extremities, like your legs or your hands? Nothing? Okay, that's good. So next, I'm going to have you expose your chest. So I'll have her remove her shirt, and for video purposes, she will be in a sports bra. Okay, so what I'm going to do here is I'm taking a look at her chest, making sure that it's nice and pink, there's no bruising, no signs of cyanosis or pallor that could indicate inadequate blood flow. And then I'm going to also look to make sure that there's no abnormal pulsations going on that wouldn't normally be there. And as I'm looking, there's no abnormal pulsations. Okay, and then the next thing I'm going to do is I'm just going to quick identify the base, the apex, and the point of maximal impulse. So the base of the heart is at the top of the chest wall. It's at the second intercostal space. right here on the right side. So this is the base of the heart, and then the apex is down at the 5th intercostal space, subclavicular, right below the nipple. And this is also the point of maximal impulse. This is where the apical pulse should be taken. And I will come back to that after. But first, before I listen to anything, I'm going to just be feeling her chest. So I'm going to have my patient breathe in and out of her mouth, and I'm going to move my hand down the chest wall and feel for any abnormal pulsations, any lifts, heaves, or any thrills. And I'll discuss those in a little bit. So first, I'm going to have you breathe in and out through your mouth. In and out. In and out. And in and out. Okay, so while I was assessing her, I didn't feel any heaves, lifts, or thrills. So I'll start by discussing those a little bit. So what lifts are sustained systolic outward movements of the chest wall, and which is an abnormal finding. So my hands would be going out, and it would be like a prolonged, even when she's exhaling. So those are lifts. Heaves are like lifts, but they're more prolonged, and like I said before, systolically sustained, and these could be indicative of heart failure. And then lastly are thrills, and thrills are typically their vibrations felt throughout the chest wall, and this could be indicative of murmurs. It could be rapid or abnormal blood flow through the valves. So those would be abnormal findings, and we don't want them, but as I was assessing her, I did not find anything abnormal. Okay, so the next thing I'm going to do is I'm going to check her peripheral pulses. So I'm going to start in the neck, and I'm going to check her carotid. Okay, and then I'm going to her wrist, and I am checking her radial. Okay, and next I'm going to go under her knee and feel the popliteal. And you can straighten that out. Sorry. You can't really see. And then next I'm going to check her, I'm going to lift your leg a little bit. I'm going to check her post-tibial, which would be back here. And then her pedal pulse, which would be here at the top of her foot. Alright, and those seem intact. So the next thing I'm going to do is I'm going to listen to her apical pulse. And as I mentioned before, the point of maximal impulse is right here at the apex of the heart. So this is where I'll be listening for 1 full minute. For video purposes, I'm not going to listen for the full minute, but I'm going to reenact it. So, apex is at the 5th intercostal space, and I'm listening with my diaphragm. So I'll have that here, and I'll have it for a full minute. So I'm listening. Okay, and then next what I'm going to do is I'm checking for a pulse deficit. So I listen to the apical pulse, and for a normal person, the rate should be between 60 and 100. And we'll say that my patient's pulse is at 78. So now I'm going to feel for her radial pulse. Okay, and I'll feel for a full minute. So if her radial pulse is 78 and her apical pulse is 78, then the pulses are equal, and that's a good sign. However, if I were to listen for a full minute and feel her radial pulse and they were completely different, that could be a sign of atrial fibrillation or atrial flutter, which can mean that there's backflow in the heart, and that would be an abnormal finding. Okay, and that's a pulse deficit. So now I'm going to review some of the landmarks of the valves, talk about them a little bit, and then talk about sounds S1, S2, S3, S4, abnormal findings, and stuff like that. So I'll start with the aortic valve. So I'll go to the sternum and to the 2nd intercostal space to the right, and this is where I would hear the aortic valve, and I'm listening with my diaphragm. So aortic valve, 2nd intercostal space on the right. And then right across from it on the left side, still in the 2nd intercostal space, I would hear the pulmonic valve. And then as I move down to the 3rd intercostal space, I will hear Erb's point. As I move down to the 4th, I hear the tricuspid valve. And as I move down to the 5th, I hear the mitral valve. And then if I go slightly more to the right under the nipple line, then that is the apex again. Okay, so I will come back to those. So next I'm going to talk about S1. S1 is the lub sound of the heart, and that is when the mitral valve and the tricuspid valve are closing. So that is when the ventricles are depolarizing or contracting. And typically, S1 sounds are best heard at the apex of the heart because the mitral and tricuspid valves are heard here. So you can hear them best at the apex of the heart. So midclavicular, 5th intercostal space, right by the nipple, or right below the nipple. And then next is S2, and that is the dub sound of the heartbeat, and that is when the ventricles repolarize, so they're at rest. And that is typically heard at the 2nd intercostal space because that is when the aortic and the pulmonary valve close. So you can hear it here and here. And then Erb's point at the 3rd intercostal space, that's when you can hear S1 and S2 equally. Okay. Next, I am going to talk about S3. So S3 is when it's called a ventricular gallop. So if you were to hear an S3 sound, it would be after S2. It is normal for young kids and young adults, but if you were to hear it on a older person, it could be indicative of heart failure, mitral and tricuspid regurgitation, and cardiomyopathy. And then lastly, S4 is called an atrial gallop. So that is typically heard, if it's even heard, it's heard before S1. And what this indicates is this is when the atria are contracting, and typically you'll hear S4 when the atria are contracting and trying to push blood through a resistant valve. So this could be due to hypertension, it could be due to left ventricular heart failure, it could be hypertrophy of the heart, it could also be from cardiac ischemia. Lastly, and I think that after that, I would assess for any abnormal heart sounds. So what I'm going to have my patient do is I'm going to have her lay on her left side. And what this does is it kind of moves the heart a little bit closer to the chest wall. And typically we can hear murmurs and pericardial rubs. So I'll talk more about those, but I'll have my patient lay on her left side, and I'll be listening to her heart sounds. So I'll start at the apex, then the mitral, the tricuspid, Erb's point, the pulmonic, and then the aortic. So I'll lay on our left side, and I'll be listening to these with the bell of the stethoscope. Okay. Okay. So apex, mitral valve, tricuspid, Erb's point, pulmonic valve, and then the aortic valve. Okay, and then to talk a little bit about murmurs. So what murmurs are is they're turbulent blood flow, and that's an abnormal finding. These are typically graded on a 1 to 6 scale, 1 being a faint murmur, so you can barely hear it, and 6 being really loud. And typically, if a patient were to get to a 6 graded murmur, you might feel vibrations with it as well. Next, I could also hear a pericardial rub, or pericardial friction rub, and typically what this means is that the visceral and parietal part of the layers of the pericardium are rubbing against each other due to inflammation that could be from infections such as pneumonia, endocarditis, and maybe tuberculosis. And what that sounds is like a grating or like a crunching, scratching sound because they're rubbing together. And I don't know if I stated this before, but if I were listening to the murmur, then that would be like a swooshing kind of sound. Lastly, what I'm going to talk about is regurgitation and stenosis. So I'll talk about stenosis first. And what stenosis is when a valve in the heart doesn't open all the way. And what this typically means is that the blood isn't able to flow forward like it usually is. So some of it stays behind and it kind of pulls a little bit. And then what regurgitation is when a valve doesn't close all the way. So what this causes is backflow, and this could cause pooling, and then this could lead to blood clots. So those are abnormal findings. Next, I want to talk a little bit about assessing my patient's skin, her peripheral extremities, and talk a little bit about arterial and venous insufficiency. So I want to talk about the importance before I even start assessing. The importance for looking at their skin, their temperature, the color, and then looking for edema. This could be signs of venous insufficiency or arterial insufficiency, and that could mean that either the blood is pooling at the extremities or that there's not enough blood going to the extremities, and these could be indicative of heart failure or any other kind of cardiac disease, and a lot of that is observed on observation first, and then moving more in depth to the cardiac assessment. So I'm gonna have my patient lay down quick, or actually she can stay sitting up. What I'm doing here is I'm looking at her legs. So I'm going to talk about arterial and venous insufficiency. So I'll start with arterial insufficiency. So what arteries do is they carry oxygenated blood away from the heart. So when a patient has arterial insufficiency, their extremities aren't getting enough blood. Typically you can see intermittent claudication with these patients, and what that means is that they can have pain in their extremities at rest. Next, their skin will look shiny, it'll be hairless, and people would describe it as pallor, which means that it's pale, it's not pink like it usually is, and if they have ulcers, they will be deep inside and pale. Next is venous insufficiency, and venous insufficiency is focused on the veins, and what the veins do is they carry the blood back to the heart so it can get reoxygenated again. So if a patient has venous insufficiency, the blood isn't going back, so what that means is that it's pooling. So typically with patients like this, you'll see edema, which is swelling in the could be in the lower extremities or throughout the body. Typically around the ankles, you'll see it the most. Their skin will look red, their legs will be puffy, beefy red, warm to the touch, and they'll have a lot of pain and cramping, and that is due to the blood pooling, and this could lead to clots. And those are both abnormal things. We want good, adequate circulation. Next, I'm going to be assessing my patient for orthostatic hypotension. So typically how this is done is I'll have my patient lay down. I'll be lay down. And for video purposes, I won't actually do the whole 5 minutes, 2 minutes, and then 2 minutes, just to save time. But I'll have my patient lay down for 5 to 10 minutes, and then I'll take her blood pressure and her pulse. Then I'll have her sit up for 2 minutes, and then I'll take her blood pressure and her pulse, and then I'll have her stand up for 2 minutes, and then after 2 minutes is up, I'll take her blood pressure and her pulse. And what I'm looking for here is orthostatic hypotension, and signs of that would be if the systolic blood pressure, which is the top number when the ventricles contract, would decrease by 20 when she changes positions, and the diastolic, which is the bottom number of the blood pressure when the ventricles are at rest, and this decreases by 10. And with her pulse, if it increases by 20. These are abnormal findings. Typically, signs and symptoms of this would be lightheadedness or dizziness, and this puts the patient at risk for falls. So what I would have my patient do is I would do some patient teaching about this. I would have my patient change position slowly. So if they're laying in bed, I would have them change to a side lying position for a little bit. I'll have them prop themselves up and sit up for a little bit. Then I'll have them sit at the edge of the bed, dangle their feet, and then stand up slowly. But every single time that they're moving, they'll be moving position slowly. And that is to prevent falls and prevent the dizziness and lightheadedness and prevent injuries to the patient. So I think that I covered everything for the cardiac assessment. So goodbye.